Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Hematopoietic Stem Cell Transplantation chapter of Hematology and Transfusion Medicine Board Review Made Simple. In 1961, Till and McCullough demonstrated that the transfer of bone marrow cells from donor mice into lethally irradiated host mice resulted in formation of colonies of myeloid, erythroid, and megakaryocytic cells in the spleen. Hematopoietic stem cell transplantation is the intravenous infusion of hematopoietic stem cells designed to engraft the bone marrow and establish hematopoietic and immune function in patients with a variety of diseases. Stem cells are a population of undifferentiated cells capable of self-renewal and generation of a functional progeny of different specialized cells, called pluripotency. Proliferation of hematopoietic cells is regulated by stromal interactions and cytokines. The most primitive hematopoietic stem cells express CD34 on their cell surface. The stem cells may exit the bone marrow and travel throughout the circulation into different organs. The stem cells for transplant may be collected from the bone marrow, the peripheral blood, or umbilical cord. CXCR4 is a receptor that retains the stem cells in the bone marrow. So CXCR4 antagonist, plerixafor, highly suggest you know this for the boards, will allow the stem cells to travel from the bone marrow throughout the peripheral circulation. Stem cell mortality and morbidity rates have decreased significantly due to improved conditioning regimens, better HLA typing, improved supportive care, and treatment of infections. Transplant allows the potential use of higher doses of chemotherapy that would otherwise be fatal in a conventional setting, as well as inducing a graft versus tumor effect in the allogeneic stem cell transplant setting. Harvested autologous or allogeneic stem cells are then used to rescue and engraft the bone marrow after the induction of life-threatening myelosuppression, except in non-myeloablative allogeneic stem cell transplantation where the main goal is graft versus tumor effect. Autologous transplant. Most effective when there's direct correlation between chemotherapy dose and tumor response. The rescue is with the patient's own harvested stem cells. Disadvantages are 1. Not being able to mobilize adequate number of stem cells, for instance, the use of alkylating agents in myeloma. 2. The possibility of infusing malignant cells, which could have been collected during the stem cell harvesting and pheresis collection, back into the patient during the rescue phase. This is minimized by purging of tumor cells from the graft by either chemotherapy or monoclonal antibodies. 3. Lack of graft versus tumor effect. And 4. Long-term survivors have a slightly higher chance of chemotherapy-related MDS or leukemia. Allogeneic transplant, either match-related or matched unrelated. Chemotherapy, either myeloablative or non-myeloablative conditioning regimens, serve to eradicate malignant cells, as well as the host immune system, which may initially reject the donor stem cells. Most importantly, however, to induce graft versus tumor effect, donor immune system attacking the malignant cells. Allogeneic transplantation may be used for the treatment of autoimmunity, immune deficiency, and congenital or acquired bone marrow failures. Here, graft versus tumor effect is not needed, so graft versus host disease prevention is a priority. The disadvantages of an allotransplant are 1. Higher treatment-related mortality than auto transplants. 2. Graft versus host disease. 3. Time needed to find a donor if no sibling-related donor is available. Stem cell transplantation HLA typing. Matching of stem cell donor to a recipient is determined by comparing their tissue types, known as their human leukocyte antigen, the HLA types. Major histocompatibility complex, MHC, is located on chromosome 6 in humans and is designated the HLA region. An individual's HLA type is present on nearly all tissues in the body. A stem cell transplantation from an HLA mismatched donor can result in the recipient's immune system recognizing the transplanted cells as non-self and attacking the stem cells as foreign entities. An HLA type consists of 2 main groups, Class 1, which is the HLA-A, B, and C, and class 2, which is HLA-DR, DQ, DP. There are 6 HLA antigens considered most important for determining compatibility: 2A antigens, 2B antigens, and 2DR antigens. HLA typing is performed on blood samples or from buccal swabs obtained from the patient or potential donor. HLA serologic typing could be adequate in matched siblings, but in unrelated donors, molecular HLA typing is preferred. Genotypic HLA typing can be done using PCR. Amplification of the HLA focus followed by hybridization to specific oligonucleotides corresponding to the different alleles within a given cross-reactive group. A match is noted when the major class 1 antigen, the A, B, or C locus, as well as class 2, DR, DQ, are the same as those of the donor. Highest risk factor for graft versus host disease post-allo stem cell transplant are differences in type 1, HLA-A, B, and C, and type 2, HLA-DR. Even in a 10 out of 10 HLA match between unrelated individuals, very important to note, minor histocompatibility differences, which is peptides derived from intracellular proteins, may lead to graft versus host disease. So a 9 out of 10 HLA match between matched siblings is superior to a 10 out of 10 HLA match between unrelated donor and recipient, since matched siblings will have fewer minor histocompatibility differences than unrelated donor and recipient, which could lead to less graft versus host disease than the 9 out of 10 HLA matched sibling. Stem cells. Stem cells can be either autologous, syngeneic from the identical twins, or allogenic. The development of umbilical cord blood stem cells has increased the chance of performing allogeneic stem cell transplantation in which an HLA matched donor, either related or unrelated, could not be found. Stem cells may be available from the bone marrow, peripheral blood, or umbilical cord. Now, the different stem cells. 1. Bone marrow stem cells are harvested from either posterior or anterior iliac crest and must be infused into the recipient within 24 hours. If there is ABO blood type mismatch between the donor and recipient, plasmapheresis may remove anti-A or anti-B antibodies. 2. Peripheral blood stem cells have for the most part replaced bone marrow stem cells as the stem cell component of transplant, since they engraft more quickly than the bone marrow stem cells and are assumed to have greater graft versus tumor effect than bone marrow stem cells. One notable exception is acquired aplastic anemia, in which bone marrow stem cells are still the preferred stem cells since they cause less graft versus host disease than peripheral blood stem cells. Since peripheral blood stem cells are found fewer in numbers, it could require multiple leukapheresis procedures for adequate stem cell collection. However, the number of leukapheresis may be reduced by mobilization of the stem cells to the peripheral blood with GCSF, plus or minus plerixafor, plus or minus chemotherapy. Pheresis products may be cryopreserved in 5% dimethyl sulfoxide DMSO for frozen storage. Important since the recipient may have an allergic reaction to the DMSO during the infusion of stem cells, that's why the MD has to be present. 3. Umbilical cord stem cells. Given the immunologic immaturity of the umbilical cord blood stem cells of newborn babies, these transplants may be accomplished even though there are disparities mismatching the HLA typing between donor and recipient, as well as reduced incidence of graft versus host disease as compared to the bone marrow stem cells. However, cord-derived stem cells are slow to engraft, takes about a month, and result in prolonged myelosuppression, so increased risk of infection, and cause delayed immune reconstitution. That is why sometimes a double cord transplant is done. Nutrition partially depletes C cells from the stem cells to reduce graft versus host disease. Now, graft versus host disease is highest with peripheral blood mobilized stem cells, but it's also assumed to derive the best graft versus tumor effect, which is thought to be the most effective treatment aspect of allogeneic stem cell transplantation. Stem cell harvesting. In order to harvest the CD34 stem cells, may use chemotherapy plus or minus cytokines. GCSF. Stem cell collection is initiated when peripheral CD34 positive stem cells exceed 5 to 10 cells per milliliter. A minimum of 1 to 2 million CD34 positive per kg peripheral blood stem cells are needed for successful engraftment in recipient's bone marrow. I highly suggest you know this number for the boards. Ideally, 3 to 5 million CD34 positive cells per kilogram body weight peripheral blood stem cells should be collected, however, in the real-life setting. GCSF at 10 mics per kg per day has been the mobilization regimen of choice for allogeneic peripheral blood stem cell donors. With this regimen, leukapheresis begins on day 5 when the white blood cell count is 20 to 50,000. Plerixafor is an antagonist to CXCR4, which binds the stem cells in the marrow and increases peripheral stem cell harvesting. Risk factors for inadequate autologous collection include multiple prior chemotherapy regimens, extensive prior radiation therapy, or administration of some chemotherapeutic agents such as fludarabine, lenalidomide, melphalan, chlorambucil, and nitrous ureas. Conditioning regimens. The chemotherapy and radiation therapy prior to transplant, which serves two purposes. 1, irradiate recipient immune system so there's no donor graft rejection. 2, eradicate cancer cells, less important in allogeneic transplants due to the graft versus tumor effect of donor immune system. Important to note, those patients with aplastic anemia have more of an underlying immunologic problem. Therefore, the conditioning regimen should focus on immunosuppression rather than myelosuppression, so use ATG or cyclosporin. Conditioning in allogeneic stem cell transplantation. Myeloablative regimens typically consist of total body irradiation, TBI, and/or chemotherapy, either cyclophosphamide, 60 mg per kg times 2 days, or busulfan, 16 mg per kg over 4 days, or etoposide, 16 mg per kilogram. Side effects can be substantial, including severe mucositis, nausea, vomiting, busulfan-induced seizures, and veno-occlusive disease. Non-myeloablative regimen is preferred over a myeloablative one in the elderly since it causes less toxicity, yet it appears to preserve graft versus tumor, which may be the predominant mechanism by which the disease is cleared. Also, the non-myeloablative regimens, there's less acute graft versus host, probably due to less initial inflammation brought on by the stem cell transplant, which incites the cytokine storm, resulting in acute graft versus host. Commonly, non-myeloablative regimens combine fludarabine with melphalan or busulfan or with single fraction of TBI. Conditioning and autologous transplantation. Myeloma conditioning regimen typically uses high-dose melphalan, 200 mg per meter squared. Lymphoma conditioning regimens typically are beam, carmustine, etoposide, cytarabine, melphalan, and CBV, cyclophosphamide, carmustine, and etoposide. Cyclophosphamide or alternatively cyclophosphamide 60 mg per kg times 2 days plus ATG for autoimmune diseases. Complications of allogeneic stem cell transplant. 1. Graft versus host disease. As acute graft versus host and chronic graft versus host share common features, the new National Institute of Health Consensus Conference now has proposed definitions of acute graft versus host disease and chronic graft versus host disease to be based on signs and symptoms rather than time of onset. Acute graft versus host disease case report. 45-year-old man with AML-M2 with four-sided genetics, status of induction chemotherapy with complete response to consolidation with a 5 out of 6 HLA matched unrelated allo stem cell transplant. On day 14 post-transplantation, the day of the engraftment, he develops generalized erythematous proteotic rash, severe diarrhea, elevated bilirubin, and elevated GGT. All blood cultures negative, CMV PCR negative, and biopsy of the skin rules in graft versus host disease. Risk factors for acute graft versus host disease include HLA disparity between donor and recipient, increasing age of host, graft type, umbilical cord blood lower rate and peripheral blood stem cell higher rate than bone marrow-derived grafts, gender disparity between donor and recipient, and alloimmunization of the donor, usually in multiparous women who've seen multiple paternal antigens. Acute graft-versus-host disease may involve the skin, rash, gastrointestinal tract, diarrhea, and liver elevation in LFTs, caused by cytokine storm, which causes infiltration of T effector and NK cells into target tissue. Graft-versus-host disease prophylactic regimens consist of either calcineurin inhibitor, tacrolimus or cyclosporin, plus short course of methotrexate to be tapered by the second or third month post-transplant and off by the 6th month post-transplant. May consider depleting the T cells with ATG, but that would decrease graft versus tumor as well. Treatment of acute graft-versus-host is high-dose steroids. Remember, 2 mg per kg per day. That's an important number to know. Mycophenolate, anti-TNF-alpha, anti-CD52 antibody, and extracorporeal photopheresis. Chronic graft-versus-host disease case report. 23-year-old woman diagnosed with severe platelet anemia, status post, allogeneic bone marrow transplant. Graft-versus-host disease prophylaxis was performed with cyclosporin A, methotrexate, and corticosteroids, initiating 2 mg per kilogram on the 8th, 20th day, then 1 mg per kilogram for 21st to 40th day, then tapered to 0.5 mg for 41st to 50th day after BMT. On day 140th post-transplant, patient develops skin rash, elevation in LFTs, diarrhea, oral mucosa dryness. She is initiated on cyclosporin and prednisone, 1 mg per kg per day. On the 300th day post-transplant, the patient still has symptoms of chronic graft-versus-host, including xerostomia, severe oral cavity pain, lichenoid hyperkeratotic plaques involving the gingiva and present, as well as hyperkeratotic plaque-like lesions surrounding the ulcerative lesions in these areas. Chronic graft-versus-host disease resembles autoimmune disease, such as lupus, Zika syndrome, or scleroderma. The chronic graft-versus-host includes skin hardening, sclerotic features, esophageal strictures and webs, bronchiolitis obliterans, alopecia, nail loss, joint stiffness, dry eyes, dry mouth, muscle weakness, hematuria, and hematopoietic system thrombocytopenia. Major cause of death, opportunistic infections from immunosuppression from both the medicines as well as the graft versus immune system effect. Treatment, increased immunosuppressants, steroids, photopheresis, and rituximab. Diffuse alveolar hemorrhage. Case report. 35-year-old female diagnosed with AML M5, status was induction and allo stem cell transplant. Presenting with increasing shortness of breath, hypoxia, and non-productive cough. A chest film, CT scan of the chest are performed, demonstrating bilateral, rapidly worsening airspace disease, suspicious for hemorrhage versus pneumonia. Now the key word is bronchoscopy is performed, which reveals, remember this, bloody fluid laden with large number of hemocytin-rich macrophages. That's the key word. No bacterial, fungal, or viral organisms are identified. Diffuse alveolar hemorrhage is a non-infectious pulmonary complication of bone marrow transplantation that is associated with high mortality. It can occur in the first weeks of stem cell transplantation. And again, think of it when the BAL of patient reveals increasingly bloody returns. Treatment, steroids, methylprednisolone, 1,000 mg IV for 3 days, then taper, aminocarotic acid, SF-beta coagulopathy, and platelets. Try and maintain about 50,000. Transfusion support after stem cell transplantation. Transfuse of hemoglobin is less than 8 or platelets less than 10,000, generally speaking. Platelets and blood components to be transfused should be irradiated to reduce donor lymphocyte-induced graft-versus-host disease and filtered to reduce HLA alloimmunization to donor antigens and minimize CMV transmission. ABO mismatch transplant recipients had a slightly slower neutrophil recovery. The mature erythroid progenitors do express ABO antigens, and immune-mediated delayed erythropoiesis with reticulocytopenia can occur, leading to prolonged transfusion dependence up to 1 year after transplantation. A more important concern is the phenomenon of immune hemolysis from mature, competent passenger lymphocytes. Transfused with the stem cell components, hemolysis can occur abruptly from days 7 to 14 after transplant and can be very severe or fatal. A positive direct Coombs test distinguishes passenger lymphocyte hemolysis from thrombotic microangiopathy after transplantation due to calcineurin inhibitors. Infections related to stem cell transplantation, very important to know for the boards and in real life. Engraftment after autologous transplant occurs within 7 to 14 days post-transplant. Engraftment after allogeneic transplant occurs within 14 to 28 days. Risk of infection is related to the timing of transplantation. 1. Pre-engraftment, less than 3 weeks. 2. Immediate post-engraftment, 3 weeks to 3 months. 3. Late post-engraftment, more than 3 months. Autologous transplant recipients are at highest risk during the pre- and immediate post-engraftment period, whereas allogeneic transplant recipients are at risk during all 3 phases. In initial post-conditioning and post-transplant period, the pre-engraftment and neutropenic period, bacterial infections are the most common, so prophylax and treat early. Bacteria commonly arise from 1. The skin, gram-negative staph, MRSA, 2. Oropharynx, strep viridans, 3. GI tract, Enterococcus, gram-negative bacilli. Also watch out for Pseudomonas, Stenotrophomonas, C. diff, and Listeria, to name a few. Reduced intensity of non-myeloablative conditioning regimens which cause engraftment to occur more quickly, decrease risk of bacterial infections, whereas umbilical cord transplant, which takes longer to engraft, has potentially higher risk of bacterial infections. High risk for pneumocystis carinii 2 months after transplantation, so prophylax with trimethoprim, sulfamethoxazole, or pentamidine as well. Fungal infections are a problem in allogeneic stem cell transplant patients, especially Candida and invasive aspergillosis. Remember that graft-versus-host disease and the immune suppression required to treat it for prolonged immune dysfunctioning and increased risk of infections. If patient develops chronic graft-versus-host, then will need prophylactic antibiotics longer. Viral infections such as HSV1, HSV2, HSV6, EBV, CMV are not uncommon either. The herpes viral infections are typically due to reactivation rather than the primary new infection. Median time to onset, HSV is 2 to 3 weeks post-transplant, CMV 100 days post-transplant. CMV infection related to stem cell transplantation. If patient is CMV positive prior to allotransplant, has a very high likelihood of CMV reactivation, so screen the first 3 months. Check for an antigenemia assay or PCR for CMV DNA. If the patient develops CMV viremia, then begin treatment immediately with ganciclovir to avoid CMV disease. CMV infections can cause pneumonitis, encephalitis, retinitis, colitis, hepatitis, and bone marrow suppression. Reduce risk of CMV infection by matching CMV negative donor with CMV negative recipient. Although this is always not possible since the HLA matching is more important, but if one has a choice between 2 donors for a perfect HLA match, then pick the donor who has CMV match as well, either both positive or both negative. If CMV negative recipient receives stem cell transplant from CMV negative donor, then to minimize future CMV infections, use CMV safe transfused products, always irradiated and leukocyte reduced, unless the patient needs blood emergency, which is a different story. Treatment of CMV disease is 2 to 3 weeks of induction treatment followed by several weeks of maintenance. Also, do not forget about RSV, respiratory syncytial virus, and influenza, which can both cause severe pneumonia in transplant patients. Veno-occlusive disease, VOD. Case report. 40-year-old man, status was allogeneic stem cell transplant using busulfan, cyclophosphamide for conditioning. BUSI. 2 days post-transplant, patient complains of right upper quadrant pain with tender hepatomegaly, increased weight gain, elevated bilirubin, and creatinine. VOD is thought to begin with injury to the hepatic venous endothelium. Progressive venular occlusion occurs and ultimately leads to widespread zonal liver disruption and centrilobular hemorrhagic necrosis. It's a major cause of death in stem cell transplantation. It's caused by busulfan-induced damage of hepatocytes. Treatment, essentially supportive care. Transplant-related bronchiolitis obliterans. Case report. A 60-year-old male, status post allogeneic stem cell transplant 3 months ago, now presenting with cough, wheezing, rales, no fever. Pulmonary function tests reveal an keyword, obstructive pattern that does not respond to bronchodilator therapy, and reduced, again, keyword, DLCO, the diffusion capacity of the lung. High-resolution CAT scan of the chest reveals bronchial dilatation. Treatment, honestly, no effective treatment exists. The patient will need supportive care and medicines. Post-transplant microangiopathy, case report. 35-year-old female, AML M0 status was induction and mismatched allo stem cell transplant conditioning. Initiated on cyclosporin, keyword, and steroids for graft-versus-host prophylaxis. Presenting with sudden onset anemia, thrombocytopenia, renal failure, and seizures. Decreased haptoglobin, elevated LDH, negative Coombs test, normal PT/PTT, so not in DIC. Peripheral blood reveals multiple schistocytes for high-power field, negative cultures, so no infection. Post-transplant microangiopathy, usually very similar to a TTP-like syndrome, which is related to cyclosporin or tacrolimus use. Events not clearly understood lead to microvascular endothelial cell damage and apoptosis, leukocyte adhesion, and activation of platelets and coagulation factors, as well as formation of microthrombi. This entity does not respond to plasmapheresis, as does TTP, since it's not ADAMTS13 driven, but renal podocyte damage driven from cyclosporin. Treatment, discontinue cyclosporin and tacrolimus and supportive care. Plograstin, GCSF post-transplant, will lead to more rapid engraftment, quicker recovery of neutrophils, but no difference in mortality. And post-peripheral blood bone marrow transplant, filgrastim may not be necessary, but that is controversial and many people still use it. Post-transplant lymphoproliferative disorder, case report. 35-year-old male with a history of blast crisis CML, status was matched unrelated donor allo stem cell transplant 1 year ago, currently on immunosuppressive medicines for skin graft versus host, presenting reticuloadenopathy, Epstein-Barr PCR positive. So seen in T-cell depleted state secondary to immunosuppressive medicines. Treatment, decrease immunosuppressants, rituximab, and consider donor lymphocyte infusion. Hemorrhagic cystitis. 40-year-old female, status was matched sibling allo stem cell transplant for high-risk AML after first complete remission presenting with hematuria following engraftment. Did not receive cyclophosphamide as conditioning regimen, so this is not the hemorrhagic cystitis induced by cyclophosphamide. Viral etiology has been reported, BK virus. Treatment, bladder irrigation and platelet transfusions, and if no graft-versus-host disease, then consider decreasing immunosuppression. Stem cell transplant in aplastic anemia patients. The patient has received no transfusions, then with cyclophosphamide ATG conditioning will have a very high chance of successful stem cell engraftment from HLA-identified sibling. The patient has transfusion-induced sensitization to transplantation HLA antigens from receiving multiple blood transfusions, and cyclophosphamide conditioning alone will cause 30% graft rejection, but now with cyclophosphamide ATG conditioning, much less likely chance of this occurring. Donor lymphocyte infusion, DLI, case report. 56-year-old female with a history of AML, status was allo stem cell transplantation, who is now relapsed. What to do next? If burden of disease is low, withdraw immune suppression. If the burden of disease relapse is high, then consider chemotherapy plus DLI. Donor lymphocyte infusion is done to induce additional graft versus leukemia effect. Donor lymphocyte infusion entails a collection from the original donor of peripheral lymphocytes during an apheresis procedure. The lymphocytes are then simply infused into the patient with either immediately or after frozen storage. And it can also worsen graft-versus-host disease and, worst case scenario, cause marrow aplasia. ABO mismatch in stem cell transplantation. If recipient is type O, meaning will have anti-A or anti-B IgMs, and the donor is either type A or B, then either remove RBC from the donor infusion or perform plasmapheresis on the recipient to remove the isohemagglutinin antibodies prior to stem cell infusion. If some of the recipient's lymphocytes survive the myeloablative conditioning, then they may produce antibodies to the transplant donor-derived erythrocytes after transplantation, leading to reticulocytopenia and pure red cell aplasia. It's a must rule out parvovirus though. Chimerism test. If donor and recipient are the same sex, need to map each person's genome prior to transplant to know which areas to map. Again, use restriction fragments like polymorphism. RFLP analysis of the donor and recipient bone marrow allows the detection of polymorphic markers to distinguish DNA from the donor and the recipient. Post-transplant means RFLP to detect those regions and differentiate between the donor and the recipient. Now, if the donor and recipient are different sexes, then simply fish for Y chromosome. For instance, if donor is female and the recipient is male, then depending on the percentage of cells that have the Y chromosome, you can determine the percentage of chimeras. Post-umbilical cord diarrhea syndrome. Patient presenting with diarrhea 7 days post-umbilical cord transplant with negative infectious workup and GI biopsy revealing quote-unquote granulomatous inflammation. Very important to remember, gastrointestinal graft-versus-host biopsy will reveal apoptosis. If you see biopsy consistent with granulomatous inflammation, that's post-umbilical cord diarrhea syndrome. Again, stem cell transplantation can be used in many liquid tumors, including AML, ALL, CLL, Hodgkin's, non-Hodgkin's, MDS, myeloma, amyloidosis, aplastic anemia. It can be used in hemoglobinopathies. It can be used in autoimmune diseases and immune suppressive diseases, in congenital marrow failure diseases, and metabolic disorders, and some relapsed oncologic tumors such as germ cells, neuroblastoma, and Ewing sarcoma. So it's a very useful tool. This concludes the hematopoietic stem cell transplantation chapter. Thank you.